So with the BTK inhibitors, specifically with ibrutinib, we know a lot about long-term safety profiles. The toxicities that are of concern with ibrutinib are atrial arrhythmias, which happen in about 10 to 15% of patients, much less likelihood of ventricular arrhythmias, less than 1%. You can see hypertension up to 30%, grade 3 or higher, and that's something that actually happens more commonly with longer durations of therapy. And then you can see other side effects that are more common but less dangerous, things like arthralgias, fatigue, upper respiratory infections. With acalabrutinib, it seems like you probably do see some atrial arrhythmias and hypertension, although it seems to be much less frequent than with ibrutinib. You tend to see less bruising with acalabrutinib than ibrutinib, less arthralgias. You see headache with acalabrutinib, which you don't see with ibrutinib, although that's predominantly low grade and goes away over time. With venetoclax, you can see neutropenia, especially early on, and you can see risk of tumor lysis, especially with the first ramp-ups. And then with chemoimmunotherapy, our primary considerations are cytopenias, both during therapy and prolonged after. And then with FCR specifically, you have an almost 5% risk of therapy-related myelodysplastic syndrome or AML.